Can have the next presenter, Dr. Ritika Agarwal, on subretinal worm with premacular hemorrhage.
Good afternoon, everyone. I'm Dr. Ritika Agarwal, doing FNB in vitro retina. So the topic of my presentation is a subretinal worm with premacular hemorrhage in young and unusual presentation. So a 19-year-old male patient, resident of Malda, West Bengal, presented to us with the complaint of diminution of vision in the right eye for 2 days. And he noticed this diminution of vision in the right eye after waking up in the morning, which was sudden in onset and non-progressive. It was not associated with any kind of pain, no history of flashes or floaters, no history of trauma, fever, or any drug intake. And there was no history of any coughing, sneezing, or heavy weight lifting. The rest of the past history, family history, and personal history was not significant. Coming to the ocular examination, the right eye, best corrected visual acuity in the right eye was finger counting close to face with no acceptance, whereas in the left eye it was 6/6. Intraocular pressure was 14 and 15 in both eyes, and anterior segment was within normal limits. And when we saw the fundus of the patient, then we saw a large pre-retinal hemorrhage seen over the macular area of almost size 6 disc diameters, obscuring the underlying vessels in the right eye. And the background was within normal. Rest of the background was in the normal limit in the right eye. Whereas in the left eye, the fundus was within normal limits. And then we needed to know the cause of this pre-retinal hemorrhage. So we did the fundus fluorescent angiography. And starting from the early to the late phase, there was a block fluorescence which was obscuring the underlying structure. So there was a large pre-retinal hemorrhage corresponding to the large pre-retinal hemorrhage. There was no focus of neovascularization that we could find in the right eye, maybe due to the obscuration by this pre-retinal hemorrhage, and we could not find whether it was only a pre-retinal hemorrhage or it was accompanied by a subretinal bleed. So we did another test to rule out what was the cause of this problem. So the rest of the tests like CBC and coagulopathies, there was no history, or also in the coagulation profile was within normal limits. So as the patient was very anxious and we could not find whether it was accompanied by a subretinal bleed also, the patient opted for surgery in view of early rehabilitation. So right eye pars plana vitrectomy with endolaser was done in this patient under local anesthesia. And when we did PVD induction, this hemorrhage got dispersed into the vitreous cavity, which was then extruded. And when we found out that there was a white glistening band-like structure present in the subretinal space, and there was also a bleed near the disc, so we left it untouched. And this is a fundus photo on the post-op day 1, where the visual acuity was 6/12 parts, and intraocular pressure was 12 millimeters of mercury. And as you can see, there is a white glistening band-like structure present in the subretinal space, which we could not find out what was it. So we did an OCT examination at this level, and we saw there was a rounded structure present in the subretinal space at that area. And there were two possibilities, whether it was a subretinal band or a worm. So because of this rounded structure present in the OCT examination, a strong possibility of subretinal worm was considered. So we did further investigations like peripheral smear and filarial antigen test, which was done at 2 a.m. in the night, and that was found to be within normal limit. But the absolute eosinophil count was more than the normal. It was 720 per microliter. The patient, since it was not moving, this thing was not moving with respect to the light, so it was considered to be a dead worm. And the patient was started on oral corticosteroids without any antihelminthics on tapering doses. At the post of 1 month, this structure of this worm got faded away after 1 month of the follow-up, as you can see in this OCT picture. So the favoring points in my diagnosis is there was no predisposing factor in this patient of 19-year-old male that led to this big pre-retinal hemorrhage. There was presence of peripheral eosinophilia. OCT findings revealed a rounded structure present in the subretinal space, which got faded away with the help of corticosteroids. And the patient belonged to an endemic area, which is endemic for which area. So there is a condition called diffuse unilateral subacute neuroretinitis, which is a clinical syndrome which is caused by motile, white, glistening, non-segmented nematode wandering in the subretinal space, and it occurs mostly in the children and young adults with a period of activity and remission. So there is an early phase and a late phase, which is vitritis, and in the late phase it is followed by optic atrophy and narrowing with major retinal vessels. So many worms have been studied in the past, like Toxocara, Ankylostoma ascaris, Strongylitis, Baliascaris. So these are the various case reports that have been published in the past. This is the toxocaracanis case report in which they treated it with only oral antihelminthic drugs. There is a subretinal worm present in the macular area. And then there are other case reports in which in the macular area there was subretinal worm and it belonged to Belli ascaris and it was treated with laser photocoagulation. Similarly, there were case reports on Witcher area in which it was found in the anterior chamber causing panuveitis. And there was a subconjunctival worm in the subconjunctival space also. Other case reports where when the onchocerca was present in the vitreous cavity and was extruded with the help of a pars plana vitrectomy. Other case reports of echinococosis.
Need to conclude.
Okay. Yeah. Yes. So the take-home message is that early diagnosis and treatment of diffuse unilateral subacute retinitis leads to a better visual outcome, and it should be kept as a differential diagnosis in the young patients. So laser photocoagulation is an effective method to halt the progression of this disease, and systemic treatment have an inconclusive role in destroying the live worms in few patients. Thank you, sir.
What is the possible mechanism of this subhilar hemorrhage?
So the possible mechanism that we thought that it went into the choroidal circulation systemically, and then it went into the subretinal space from the choroid, and then it ruptured. The vessels got ruptured, so it led to the preretinal hemorrhage. Firstly into the subretinal space and then into the vitreous cavity. Various case reports have been published when the worm has migrated to the vitreous cavity through the ruptured blood vessels.
Picture, the
Yes, sir.
worm was predominantly subretin pre-RP, is it?
Pre-RP, yes, sir.
But it was sort of between the neurosensory retina and RP.
So clinically it was found to be subretinal, but in the OCT figure I thought that it is subretinal or intraretinal, like it is present before the pre-RP, but it is present, like I cannot find this neurosensory retina here in this figure.
But tell me, how did it disappear after a few weeks?
So it was considered to be it was like hypothesized to be a dead worm because it was not moving with the light.
Body finished it off.
So we gave a tapering doses of oral corticosteroids. So it was to contain the inflammation. That is, the natural course of the worm is like that only, that it gets disintegrated in the later stages.
What was the B-scan picture like before the surgery? I did not catch the B-scan picture before the surgery. Did you do one?
So B-scan we did, but I don't have the picture. There was no retinal detachment that was associated with it. So the main thing was that we could not find whether it was associated with a subretinal bleed or not. So that's why the surgeon went ahead with the surgery.
And you are very sure that it was a worm, nothing else, no subretinal bleed?
So we are not sure. There was a strong possibility of a worm. Actually, we do not know what is it. So the strong possibility of worm was considered with the help of these favoring points. So we are not sure.
Okay. Thank you.
Thank you, sir.